Okay. So I can't see anyone, but that's all right, I guess. Well, so thank you, Sophie, and thank you, Roman. Thank you, all of you who joined us today. I hope the next hour or so will be quite interactive, and we can discuss around how the platform can help capture outcomes in long COVID. So we've kept the kind of seminar, I guess, very focused on PROMs. I'm Manoj Sivan. I'm associate professor and consultant in Leeds. I'm also the research lead for the Leeds long COVID service. And My team basically developed the PROM, the C19 virus, the Yorkshire Rehab scale. So for the next 10-15 minutes, I will briefly talk about how the scale was developed, what the scale can do, and the kind of the future prospects. I know that we've got people from lots of kind of long COVID services in the country who use the platform. So it'll be good to discuss how we can collaborate and learn together in this novel condition where there's lots to be learned yet. Now, how do I... Yeah, so those are the things I plan to discuss, talking about the original C19 virus and then how we modified the scale. And then really the play for my talk is how we should try to reduce the administrative burden for patients, because it's all about patients, and how we should be using as few condition-specific outcome measures as possible. And that's the main kind of the message from today's talk, my talk. That's just a kind of a timeline of all the work we've done. We've been very active right from the first wave, and that's when the scale started developing, where it basically was a screening tool to pick up symptoms in patients who were getting discharged from hospital. And then there's a journey which I'd like to talk about how the scale developed, but it's used widely now, nationally and internationally, in clinical practice and in research. So that's when the first tool was published. Since then, it's been translated in numerous languages, and it's used in all those countries. So in terms of the content validity, so this question is asked as to, well, is the tool doing its job? It does, because this was a study which was done again around that time, June 2020, where we did the first follow-up study, and these were the symptoms which were picked up using that tool in patients getting discharged from hospital. And you can see the kind of symptoms which were picked up are actually the common symptoms which many other studies have shown in this area. So that basically proves the kind of the content validity, that it's doing its job of picking up the most important long COVID symptoms. And very grateful to NHS England to back up kind of our tool, and then recommend our tool is used on a regular basis. And that's where actually the idea for converting the screening tool to a proper outcome measure came, as in that guidance in November, it was mentioned that the tool could be used at frequent intervals, because it's got each symptom has got a severity scoring. So pretty much it could be used at multiple time points to capture change. And that's where the idea for a scale came. And we then developed the what is called the original self-report version of the C19 virus. You probably have seen this, so I don't need to go into the details, but it basically, each of the symptoms is scored on a 0 to 10 scale of severity, 0 being not present, 10 being most severe and life disturbing. And you both score for before COVID and currently how you are now. The 10 symptoms, so breathlessness, cough, pain, fatigue, depression, anxiety, PTSD. So 10 core symptoms are then added to get a symptom severity score out of 100. Then there are functional disability domains of communication, of mobility, ADLs, which can be then added together to give a functional disability score out of 50. Then there's an overall health question, just as simple like a EQ5D VAS of 0 to 10, where you've got to say, where do you think your overall health is? So it's pretty much like the EQ5D final question. And as symptoms were emerging, now this is it was an evolving scale, because we were seeing patients, we were getting feedback, we were doing numerous rounds of kind of development of the scale with patients. And as new symptoms started emerging, then we added them in additional symptoms, and there were 6 of them in that scale. And that gives a score of 60, because each of the 6 again is scored on a scale of 0 to 10. It's a self-report, it's a free to use outcome measure, can also be completed by the clinician or a family member, as I said. And then we did some validation and psychometric analysis, property analysis of the data which came from the Leeds long COVID service. And you can see, we don't need to go into the details, but it is a decent Cronbach alpha for reliability and internal consistency. And these are some of the correlations bottom, looking at the different kind of subscales. How do they correlate to each other? So 0.7, around that figure is good. And you can see that minus correlation for overall health, because I would like to highlight that the overall health is in a reverse direction, 0 being worst health and 10 being the best health, whereas all the other symptoms are 0 being no symptom and 10 being the life disturbing. So it's in a reverse direction. So one would expect the correlation to be negative. So next step was to do what is called the rash analysis. Now, the reason rash analysis of a scale is done is we are adding up item scores to get a summative score. And rash analysis basically tells you whether you can do that or not, whether your scale is kind of behaves like an interval scale or not, and whether you can add up your symptoms. So you can look there when the analysis was done. This is called the threshold curve of the probability curve for those different responses. So those different color graphs are basically, for breathlessness, it's the 0 to 10 is the probability curves for people responding to those different responses on that 0 to 10 scale. And you can see that it's all kind of clustered together. It's not kind of equally distributed, meaning that the responses are not delineating patients between each of the response categories. So in a sense, what it's saying is the 0 to 10 response categories are not working, and you probably need fewer of them. And that was why in the modified version, we clubbed actually all the response categories into 4, so that you just have 0 to 3, which is none, mild, moderate, and severe. So you can see an example for breathlessness where the current scale only has 0 to 3. And you can see the post-hoc analysis shows those nice graphs, which is what a scale is supposed to do, that delineate between the responses properly. And this is what the modified C19 virus does. And it also kind of backs the rationale of adding up scores to give a summative score. So basically the new scale looks like that. So it's exactly the same, but we've done some rearranging. We've taken all the dichotomous behaving responses, like the continence can only be yes or no, can't have different grades in it. The swallowing is similar, you have a problem or you don't. So those kind of dichotomous response ones have been moved to the other symptom category. And then the symptom severity have got a few new core symptoms, like the PEM, which didn't feature in the original version. And we all know that PEM, and otherwise called the PESC, is the hallmark characteristic symptom of long COVID. So that is featuring in the modified version. And there's a few other changes, other symptoms have been added. So now you get sort of similar structure, where you get a total out of 30 for the symptom severity, you get out of 15 for functional disability, or you could also call it functional ability if you don't like the term disability. Overall health is out of 10, and other symptoms out of 25. So this is the kind of the scale which is now widely used, and in other studies as well as clinical practice. But I think it's still perfectly okay if people are still using the original scale, but it just lacks those new symptoms which have been added to this scale. It takes in less than 10 minutes, actually, put there 10 to 15, just, considering people with brain fog and the ones who kind of take a bit longer. This is some of the work we did, again, looking at how those mild, moderate, severe categories work. And what's very interesting here is that kind of severity phenotypes, which clearly stood out in one of the studies we did. What this means is basically patients, when they score severe for one particular symptom, they tend to score severe actually on other symptoms as well. So it's either could be a response bias when somebody is just responding severe on everything, or actually that is a real condition, that you have this fluctuating condition where you're mild on a day where you're mild on all the symptoms, and when you're severe on all the symptoms. So there's this nice graph, the radar plot you can see, and which keeps changing from that small kind of radar plot to a bigger radar plot. And that nicely kind of illustrates the fluctuating nature of the condition. But even though this one is not, it's a cross-sectional study, it's not a longitudinal study, but it'll be interesting to see longitudinally whether we get similar graphs from patients. This is again one of lovely graphs from Darren, who's a statistician who's done all the work, and this is kind of cluster analysis looking for symptom phenotypes. So this is not severity phenotypes, this is seeing whether there's any pattern of symptoms, and you can see there's not great deal of clustering which has been identified. So from that graph you can basically conclude that you can't actually pick up a group of symptoms as a particular cluster. I know there's been a lot of talk and literature around it, but then this was a very small sample, and we hope to do the same work on a larger sample to see whether we can actually identify, would there be a pain predominant phenotype or a fatigue predominant phenotype and an allergy predominant phenotype. So work, it remains to be shown actually in data like this using the scale. So there'll be more talk about the ELAROS app, but it's just to say that it's a neat app which can provide the ability to all these different scales to be measured in one place. Patient has access to it, they can fill it at home. It's available for them to see their own results. They don't have to waste time in busy clinics filling out paper forms. And it's a two-way kind of communication between the clinician, because they also have access to the digital system. So this really, before I conclude, is the essence of the talk, that long COVID is a multi-system condition. It affects a lot of body functions. It affects persons' functional abilities, social role, vocation. And there is also always this personal factor and environmental factors which come into play, where you are, which, what's the culture, your religion. So those are kind of the personal factors, and environmental factors as well. What kind of setup are you in? What sort of support you've got at family, and what support you've got with your healthcare system? That is the environmental factor. So any condition, not only long COVID, you need to make sure that it captures all of this for a condition. And given long COVID is such a multi-system condition, we need measures really which capture all of these domains. And that's why C19 virus is very carefully being built on this model, which is the WHO's ICF model, that we do capture these different domains, and we have subscales for these different domains. And we wrote about that in BMJ. I wrote this with Melanie Calvert, whom has developed the symptom burden questionnaire, which is again another condition specific for long COVID outcome measure. So the future developments really are this ongoing cultural adaptation of the scale in many countries, and we have the Locomotion NIHR funded project, which is across 10 NHS sites, where we'll do further kind of validation and testing of the modified version, and also all the kind of other work I mentioned on looking at phenotypes and other things. There is something else which I would like to discuss. It's just happened last week. We were discussing with NHS England that given we have such rich resource of all clinics using the platform, is there something which we can do working in collaboration with NHS England and with all of you here present on the call, and if not, whoever's using the platform, whether we could actually come up with a plan to look at the data which is being collected. Now, if you remember, the ELAROS app asks patients at registration very clearly whether they're happy for the data to be shared. So if there is an agreement between the clinics and ELAROS and NHS England and us, then we could probably look at the ones who've agreed for their data to be shared. We can sort of extract the anonymous data and look at some long-term outcomes, because we're all interested in knowing what's happening to these patients. And NHS England is also interested in knowing, well, what's happening to these patients long-term, how many are fully recovering, how many end up with a chronic long-term illness, and what are the outcomes of these specialist clinics, the 90 clinics. And what is, well, the key question, the crux is, if there are commissioners here, is are they cost effective? Are these clinics, should they just be managed in existing clinics, or do we actually need specific specialist long COVID clinics? And the answer is in the data, to see how people are changing, how much money is being spent on these clinics. And we've got different service models as well. Not all clinics have got the same service model. They're different. Some are in primary care, some are in secondary care, some are interface, some are led by respiratory medicine, some are led by rehab. So there's a good mix there. So I think, and there's rich data which ELAROS platform has. So I think if we all come together, there is an opportunity to look at a long-term kind of outcomes project, which we can discuss in due course. So this is just kind of a discussion from last week. So there's more to come on this. My recommendation generally would be that ELAROS provides you the ability actually to select outcome measures. You're not forced to use even actually the C19 virus. You could use SPQ, or you could use anything else. My recommendation would be use one condition specific measure, use one health related quality of measure. Think about ICF. Don't burden patients with multiple outcome measures, you know, one for breathlessness, one for fatigue, one for pain. You will be missing symptoms, and B, it is not meant to do that, because it's a new condition. We need new measures which can comprehensively capture the condition. And think about the patients, you know, with people with brain fog. So you need to be careful what we're asking them to complete. So it needs to be minimal. It needs to have as less burden as possible. Some references, very happy to share that. And like to thank a lot of collaborators there on the slide. Thank you.
Thank you very much there, Dr. Savan. I think that was a really, really useful overview as to how it's been used in clinical practice and some of those early benefits that have been seen as well. I think if we hand over to questions at the moment. Roman, is there anything that you wanted to add there before we go on to questions?
No, not from me. I've just seen a few questions around pricing. Ultimately, this depends on whether it's a public health funded clinic, whether it's a research study, really what's needed for the study. I've noticed Janet's has kind of quoted a price there, but this required some development time in order to deliver that project. So it really depends on what the local clinic or research team needs.
Mm-hmm. Yeah, Janet, did you want to expand there? I can see you've popped a question in around GI symptoms as well into the chat.
So anyway, I had a couple of other questions about the PROM itself rather than of the app. I'm interested also in GI symptoms, particularly, which at least the last version of the PROM didn't really cover that well. I wondered if that's something that you've added in now.
So there is actually, if you look at, can you hear me?
Yeah, loud and clear.
Yeah, okay, just 1 second. I think the modified version, I'll double check before I make a claim, but the modified version, if you go to other symptoms, so you've got constipation, diarrhea, bowel incontinence. It also covers bladder frequency, urgency, incontinence, talks about weight loss, weight gain, nausea.
Right, that's fine. So they're just plus minus, yes.
Acid reflux, yes. So these are the dichotomous items which go into the other symptoms.
Right, I see. And how, for example, the breathlessness, that have you done some correlation with other existing PROMs like the MRC dyspnea score, or for fatigue, likewise, there are various fatigue scores?
Yeah. So there's a very interesting piece of work which has come from Italy. Actually, what they've done is they've looked at the different responses of C19 virus, and they've correlated them to full scales for each of breathlessness and fatigue and pain and quality of life, and they have found that the correlation is quite good. So that's published in a journal called IGERPH. I'm very happy to share that publication. I'll put the kind of the reference in there in a minute. But it's been done. That work, when we were hoping to do that, but I think the Italian team beat us to that.
That'd be interesting. Thank you.
Brilliant. Thank you very much, Dr. Sven. I'm conscious of time. Are you around later for questions at the end of the session?
Yeah, I am.
Okay.
Yeah.
Excellent. So if we move on now to Romel Go from Cambridge and Peterborough NHS Foundation Trust. Are you on the line?
Hi, it's Ade here. Rom was meant to be presenting today, but he's not with us. So unfortunately, you've got me.
Brilliant.
Can you hear me?
We can do, yes. Yeah.
Yes, I'm just gonna just share let's just bring my presentation up. So my name is Ade. I'm a neurological physiotherapist, as well as the service manager for the post-COVID service. What my content of my presentation today will really be talking about an overview about our service and how we've incorporated the C19 as an assessment for having me. Just gonna move on. Okay, so just to begin, I just wanted to talk about just where we are in terms of how our service was set up. I'm sure you're all aware that NHS England have been promoting integrated care and services for a few years now, and all CCGs nationwide have transitioned into ICS on the 1st of July. So this was very much at the forefront of our minds when our service was set up in April last year. NHS England defines integrated care as giving people the support they need, joined up across local councils, the NHS and other partners. It removes traditional divisions between hospitals and family doctors, between physical and mental health, and between NHS and councils. So the vision for our service, for our post-COVID service, right from the onset was to create a one-stop, blended and similar service for long COVID patients in our county. We are continuing to work on this by reducing unnecessary referrals and working closely and collaboratively with primary and secondary care. So as you can see, we are county-wide, like I said, and we do offer assessment and rehabilitation for long COVID patients. So just talking about our workforce, so the workforce behind our service comes from a variety of specialisms and work in different parts of the integrated care system. So we've got primary care, community care, as well as the acute setting. The service itself is located within the community trust, but obviously work very closely with the primary care and secondary care as well. This model of delivery is very unique within our trust, and our service beautifully showcases the blurring of the primary and secondary care interfaces that can sometimes be challenging when creating new service designs. At the onset of our service, the funds for the post-COVID service has been ring-fenced specifically for our service. So again, that has worked in our favor. So within the team, we've got our clinical lead, who is a general practitioner with special interest in long COVID. And we have consultants from secondary care, from infectious diseases, neurology, respiratory, and intensivists who help with complex patients at our MDT. The post-COVID service itself is therapy-led. As I said, I'm a neurophysio, and within the therapy intervention we provide, we've got respiratory physios, neurophysios, we've got specialist nurses as well as peer support workers and rehab assistants. And we still currently do have a project lead with the ICP who helps with navigating the service. So who is affected by long COVID? Again, this is just a slide just to show where we are. I think this still emulates the national picture in terms of those presenting at long COVID services. The criteria is very much ongoing symptoms for longer than 12 weeks, which I think is what most services adhere to. We've got more women, as you can see. So we've got middle-aged white women present more for our service, and I think this is the same nationally. And we've also got obviously people with increased BMI and those with pre-existing conditions as well. I've just put on a graph again just to show the different demographics, but what we're seeing locally is very, very similar to what the national picture is as well. So just going on to referrals. So we have got a single point of access model. So all our referrals come in electronically via integrated care portal. A large proportion of our referrals come directly. I think about 95% from GP practices. And we do get direct referrals from within the acute trust as well. So the way things go is the referrals are logged on electronically by administrators. To date, we've had almost 1,500 registered referrals, 926 discharges, and currently we've got 516 live cases. Obviously, within the live cases are our waiting list as well, because once they've been registered on, their profile becomes active. So the way the referrals work, again, within the pro forma, we do require a few investigations. So things like the date of infection, full blood count, and chest X-ray as needed. At the onset of our service, we used the original self-reported questionnaire, either sent electronically to patients or posted if patients did not have access to IT. But as you can see, in February this year, we've now been using the C19 app, which I'll talk a bit more about later in my presentation. So the assessment is done by Band 7's therapist, either an occupational therapist or a physiotherapist. Again, Band 7s were required because of the complex presentation of the nature of the symptoms that patients were reporting. Generally, the assessments will take between 45 to 60 minutes, again, because of the complexities, but we were finding as well that we were needing to reassure patients because of how long they have had the condition for, and also some people who had several investigations but with no abnormality reported. Once the assessment's been completed, the outcome goes in various different ways. We use the TX system 1, 2, and 3 that fits nicely into the digital, virtual, and face-to-face arm of our service. So the clinicians who does the assessment will make those decisions. Prior to that, we do have the MDT for complex presentation. Now, most of the assessments done within the service don't all go into the MDT. So it's those who present with complex presentation. We also offer clinics in respiratory, neurology, and infectious diseases, again, for those who might require further investigations, as well as referral to other specialist services. Is worth saying at this point that our long COVID clinic, they're more or less like pop-up clinics, and we only run them 1 or 2 times a month, depending on what the outcome of the MDTs we've had on a weekly basis. So it's really based on demand. So this chart is just, just an overview of what our service looks like. So from assessment, you can progress to MDT or to the clinic only if required. Generally, these are patients with real complex presentations. So the majority will either go into the tier 1, which is, again, the Your COVID recovery online rehabilitation route, or a virtual rehab program, which I'll talk a bit about more again in the presentation. And then the tier 3, which is face-to-face, done by OTs or physios in the home setting. Also, an extension of the tier 2 is the 6 weeks peer support group that we offer to those who have completed the virtual program, who perhaps just want to share their lived experiences with other similar patients, just to continue with their journey of recovery. So that's also an offer for some of our patients. So just talking a bit more in detail about each element. So the tier 1 is the Your COVID Recovery digital platform, which I'm hoping that we're all familiar with. We generally offer this to patients who present with mild to moderate symptoms, who are reporting some signs of improvement in their symptoms, but still limited perhaps by breathlessness and mild fatigue. For example, they might be back at work but really struggling either to go back to full-time work, or perhaps even on their phased return, still struggling with a bit of breathlessness and poor exercise tolerance. Each patient is encouraged to set their own rehabilitation goals that will enhance their physical and emotional as well as psychological well-being. We encourage this group of patients to remain engaged on the platform, and we generally use the chat function within the Your COVID Recovery app to communicate and to get patients engaged on the platform. We still obviously have to document onto System 1 the RAs. We've got rehab assistants who do all the follow-ups, again, like I mentioned, via the system, and generally patients can stay on within the digital arm of the service for between 3 and 6 months. We encourage them to do it within 3 and 6 months, but actually patients can remain on the app for up to a year if they do want to. The tier 2 is where the greater percentage of our patients end up. And we, in this section, we offer a group session, which is a virtual self-management program that runs over 8 weeks. We're currently about to start the 16th cohort. So we've done several of these, and they're proving quite popular. The aim is to provide understanding about symptoms and to offer strategies to help them to improve and manage their symptoms. The layout is, again, like I said, group setting, up to 20 patients. Rarely do we ever get 20, roughly on average between 12 and 15. It's a closed group, it's not recorded. We try and churn the groups up every 4 weeks. We offer a morning as well as an afternoon session, just to give patients options. We have 2 staff members involved in each cohort. So we have a clinician who is usually the main facilitator, and admin person, just to help to obviously just moderate some questions and just keep an eye on the chat. We normally let the patients know that because it's a group, we have diverse representation in terms of the type of symptoms as well as severity. So people coming to the group at really different points in their journey. So we do need to acknowledge and manage that carefully, and that's one of the areas where the clinicians as facilitators do come in quite handy. Patients are encouraged to keep a learning diary each week, so they know what they're learning, and they're very clear about the tools and the strategies that they are going to be taking away to help their own particular situation. Sessions last 60 to 90 minutes and divided into two parts. So the first part of the session, there's a pre-recorded video, just obviously with the particular topic of the day. We've got 8 different topics represented. We do 2 on fatigue, 1 on breathlessness, anxiety and depression, brain fog, pain and exercise. I'll talk a bit more again in detail about this. At the end of the program, every single person who attends will have a follow-up call with the facilitator, and we are trying to collect outcomes by using the friend family test post-program, and there are other outcome measures that we do use as well that I'll touch on later on. So within, like I mentioned, within the group, we use these self-management videos, which were created by our service, but it's been acknowledged nationally by the NHS England. It's now NHS England approved, and they can be found on the NHS Future platform. We use each recording for each week for these topics that I've already mentioned earlier. The videos, again, are being adapted onto the Your COVID Recovery platform. They've been recorded in bite size just to enable people probably interact better on the app. Within our program, the videos can be lengthy because each video covers a particular symptom that is discussed at length during that session. So whereas on the platform, they've just been done in little bite size just to help patients to just focus on the particular area that they need it for. And this is a follow-on, and like I mentioned earlier from the virtual group, again, this is done in groups. It's optional. People log onto it if they want to. If they don't want to, they feel that they can manage their symptoms better after the initial virtual program, then we just monitor them. This is done in groups of 6 to 10 people, facilitated by a peer support worker. The content is led very much by the peers, and some emerging themes since we've been running these virtual groups include self-stigma, recovery, wellness, planning, communication, as well as self-advocacy. And finally, the third tier is home visits. So we offer home visits for patients who require maybe one-to-one more structured intervention. This is either OT or PT focused. We also offer a 6 weeks rehab program for those who want, again, to just improve their exercise tolerance. And this is supported by a rehabilitation assistant. We're not prescriptive, but we do try and combine visits as well as virtual intervention, telephones for follow-on calls as well, and reviews as necessary. Patient can move into either the digital or the virtual arm of the pathway at any point in time. I probably forgot to mention that it's not a linear pathway, that people can move from one pathway to the other. We do use recorded videos as well as part of the intervention. So for instance, if the OT is working with a patient on fatigue management, they perhaps might send them the link to the video, get them to watch it, start putting on their daily activity, keeping a daily activity diaries, as well as the face-to-face intervention for the face-to-face interventions that they will then have subsequently. So I'm now just going to talk a bit about service outcomes. Again, this is an area that is a bit challenging, and obviously NHS England also recognizes this. We are trying as a service as well, but again, as you can see, that it's a complex nature, the complex nature of long COVID, and the different services and the different presentation of the patient makes it quite difficult and challenging to do this. However, because our service was set up in April last year, just at the point where NHS England recommended the routine use of C19 at first assessment, 6 weeks and 6 months, to monitor long COVID nationally, we tried to adopt the C19 at that point in time. So we adopted the template itself. So again, just sending out electronically the original version via email, and collecting EQ5D as well on inception, mainly at assessment, and 3 months. Other measures were introduced as the rehab arm of the service developed. We introduced the app fully February this year, so it's still early for us in terms of knowing fully the full benefits. However, we do want to continue to work with it, and we are hoping to actually embed it right through the rehab element of the service as well. So this chart is just one way of showing what we're currently doing. So the app is used mainly at the assessment level, where we use the C19 as well as the EQ5D within the app. So every patient who's referred to a service will be registered onto the app by the administrators, and they will use the app to make us aware of their symptoms as well as the severity of their symptoms. So like I mentioned, the administrators registered to use the app as well as clinicians. This is an area where, again, hopefully going to continue to develop in. The administrators create the profile for the patient, and once the referral has been accepted, and they will send the link to the patient to download onto their device. The completed questionnaire is then uploaded to System 1, again by the administrators, but this is pretty straightforward compared to when we were having to email, get those, then get it scanned, in some cases photocopied as well. So I think that's actually been a positive in terms of the admin processes, really cut down on our administrative processes. Just before the assessment, the clinicians will then review the completed questionnaire. At this point in time, that sits within a system, within their System 1 records, where the assessment is going to be done, or it's usually ready for us, for the clinicians to use, because the administrators would have got that onto it. Over 80% of our patients since February 2020 have now used the app. So we can say that the app is well established for the front end of our service at the moment. Other optional PROMs have also been added, and again, based on how our service is set up, we requested to have additional outcome measures embedded within the C19 app. So currently we've got these measures. So we've got the WSAS, the Modified Fatigue Impact Scale, and Nijmegen and MRC for our respiratory physiotherapies. We use the self-efficacy scale, and then for our peer support workers, we use the long-term condition questionnaire and the Hope Agency and Opportunity questionnaire, just to measure their intervention. Again, clinicians, the plan, we're not quite there yet, but the plan is, as clinicians assess, that they will choose the appropriate outcome measure, and they will use it at the beginning of their intervention as well as at the end of their intervention within the app. So basically, if a patient is going to go, if an OT is going to see a patient, they will ask the patient to log back into their C19 app, and then just complete whatever questionnaire that they that relates to the symptom that they're going to be getting treatment for. So looking forward to when the app is fully embedded, this is what we think we would like to see. So at every point in our rehab pathway, would like the C19 app to be used in these different sections. So obviously for the one-to-one, depending on what intervention is being provided, the clinician can ask the patient to complete the appropriate questionnaire. So it's just a diagram to reflect that. So just talking about the feedback we're having at the moment, and just the advantages that we think we're beginning to see is, one, patients do love using the app. It's very easy for them to complete, and they can complete it anywhere. Whereas prior we had issues with either patients struggling to download the questionnaire, complete it, save it, and then send it back. But I think we've seen a rapid change in how patients interact with that. Like I mentioned also earlier, it's cut down our admin processes, and our waiting times as well has reduced, just because we've been able to get rid of some layers of administration. And it gives focus to assessment for clinicians, so we can literally just look through the questionnaire, see what symptoms patients are struggling with, and you can then use that to navigate the assessment. Also useful to identify patterns and trends in symptoms, and I've just got a few slides to show you how we've just used that for a snapshot audit that we recently did. So we were at the point in our service where patients were reporting pain. This is really very simple. It's really very snapshot. I think for about, I don't know, 10 patients, we just did a very, just a very quick snapshot, because we're struggling to get patients for pain referred to the pain management service, as well as the pain section of our virtual program. It was becoming increasingly difficult to get the pain management service to assist us in that. So we just thought, let's just see what we're seeing in terms of pain. And basically the outcome was what we thought we knew. So obviously patients presenting with this many types of pain. In particular, it was important for us to know what type of pain we were seeing most. So just using the app to do a very quick snapshot gave us this outcome. And what we realized is, again, asking the question, what are we doing with patients that have a high pain rating? It was very obvious that majority of them ended up in the virtual program, where obviously one of the sessions addresses pain, but in as much as it was addressing pain, we were struggling to get the pain management service to actually input into it. So the outcome of this is now that we are going to be employing a GP with special interest in pain, just to help us input into this, as well as perhaps see some patients presenting with very complex pain. So I thought I'll just leave you with this. So this is just a testimonial from one of our administrators who have been with us right from the beginning of the service, who did the bulk of the work in terms of getting questionnaires and making sure that clinicians had the questionnaire that they needed. And I think, again, like I said, it's really cut down on the time. We saved money and paper, and I just thought it'd be nice to share that testimonial with you. And finally, just next steps for us, again, is just training for staff with the app, and just getting people more confident and comfortable using it. We are hopefully trying to implement it consistently across the breadth of our service. We need to work on avoiding duplication, I think more for our clinicians, because we're all more familiar with completing some of those outcomes on system one. So there's a little bit of duplication going on, and that's why I'm not able to show you any concrete data today, because they're at the moment everywhere. But we are doing some work on that, just to ensure that we can get all our data in one place. We're also in discussion with our data guys in the trust to enable them to merge and embed the data onto system in a way that is meaningful for us to use. And they're talking about perhaps maybe connecting that to the data warehouse, and the details of which I really can't tell you, but it's something that we do want to work with them with. And again, like I said, it's making sure that it does what we want so that we can extract the data in a meaningful way for service evaluation and outcome. Thank you for listening. Any questions?
Thank you very much. That was a great presentation, and there's a huge amount of detail there around your service. And I think that there are a number of questions that have come up and comments that have come up in the chat around if you're able to share the VOC Rehab questionnaire, and if you can share the FFT you use in the groups, and if that's been adopted. Sorry?
Okay. I haven't. Yeah. I am happy to. Yeah. Probably maybe true. Yeah. True, Roman. Just to send that through. I'm happy to do that.
Yeah. I wondered if the information that you mentioned on the NHS Futures page as well, if that's easy to find, or if people need specific access to that, and if it would be useful to pop.
Yeah. So
yeah.
Yeah, I will do that, but I think people need to be registered on the NHS Futures site, and log on to the Long COVID network bit, and that will give them access to the videos on there. Yeah. Okay,
brilliant. Thank you very much. Does anyone have any other questions that they want to raise, or we can leave those until the end of the session? Are you about the end of the session after Roman's presentation?
Yes, I am.
Okay, brilliant. And sorry, there was a bit of time lag, I think, between both of us talking, so sorry if I talked over you. Roman, I will hand over to yourself for the last presentation, if that's okay.
Okay, so hi everyone. My name is Roman Roch-Lawrence. I'm the Director of Research and Development at ELAROS. I'm here to talk about NHS England's recommended PROMs and how ELAROS's platform can help to support services. So I wanted to start off with a brief agenda of my own presentation, but also to help summarise the aims of the webinar. And here I'm aiming to disseminate parts of the NHS England guidance to attendees. I do recognise there's a number of attendees that aren't just based in England. We've got strong representation from Scotland, Northern Ireland, the Republic of Ireland, and also in Australia. To discuss the use of PROMs in clinical practice, including those recommended by NHS England. To share how some of these clinical guidelines are translated into practice. To demonstrate various clinical pathways across multiple long COVID services, including such as Leeds and Cambridge. To provide an overview of our platform and to provide a demonstration at the end, time permitting. And generally speaking, I hope this webinar has been helpful in supporting clinics with the mobilisation and potential digitisation of their services. So I want to start off with an extract from the NHS England guidance. And as I say, not everybody here is part of the NHS in England, so they may have not yet seen this guidance, but a lot of countries around the world are turning to England, looking at the Leeds model, looking at how some of these kind of key research papers or kind of more established sites are kind of set up. And this just says that services should gather and analyse outcome data for children, young people and adults identified with long COVID within primary care, secondary care and specialist services. They state that patient-reported outcome measures, clinical measurements, and patient-reported experience measures help to monitor patient progress, facilitate communication between professionals, and to improve the quality of services. And this data also contributes to the evidence base on the management of long COVID symptoms and efforts to reduce unwarranted variation in post-COVID services. So this next slide just summarises the recommended PROMs that have been listed in the NHS England guidance. So starting off with adults, they've recommended the C19YRS in all three of their national guidances as early as November 2020, April 2021, July 2022. And they've also recommended the EQ5D5L and the EQ-VAS, and these are combined into one tool. They also state that additional outcome measures can be used where clinically indicated, depending on symptom presentation and to personalised management treatment approach. And the minimum recommended time points for collection of PROMs by services of first assessment, 3 months from assessment and a discharge. So looking at children and young people, the list is a little bit longer here, and they state that the completion of standardised questionnaires by children and young people is recommended at baseline and at 6 months, and as a core outcome measure for services running a treatment model. They also state that services should be aware of the risk of overburdening children and young people, but it's also worth noting that it's important for adults as well, and also their families with the questionnaires. And as far as possible, the questionnaires used should be consistent with those used in current research. So this slide just shows a diagram of all the available PROMs in our platform. The list is growing. So the list is a little bit longer than those that have been recommended by NHS England, and this is because we've added in additional PROMs as per local requests by individual sites. Some have been added in here to support research studies. And hopefully you can see these now highlighted in blue, but these are these three particular PROMs or questionnaires have been developed specifically for use in long COVID. So there's a modified C19YRS, which is used by a number of clinics already. This is pending validation. The vocational rehab questionnaire has been added in specifically for Cambridge, and this is undergoing validation by that clinic. And there's also the symptom self-efficacy questionnaire, which has been added in for Wiltshire Health and Care, and this is an adaptation of the pain self-efficacy questionnaire. Similar to those plots that Manoj showed in his presentation at the start. So when a patient completes the C19YRS, it outputs these graphs, and these are available to patients within the app, but it's also available to staff in a clinical web portal. And there are a number of different graphs that are kind of outputted or created for different PROMs. Every questionnaire is structured quite differently. So just a brief mention of some of the PROMs coming soon to ELAROS. So on the left, for adults, the top three relate to pain and pain management. We're adding these in to support a PhD student whose PhD project has been hosted at the University of Leeds, Manchester and Liverpool, and we're supporting them with that. And there's also the possibility of adding the SARIC UK follow-up global survey to support a research study in Scotland. On the right-hand side, some of the PROMs that's coming soon. The EQ5DY is a work in progress. It's quite difficult to kind of get around get permission from the licensor. The SF36, which has been recommended, that should be ready soon. And we're also about to kick off some work in the Leeds and Sheffield children's clinics, where with an adapted C19YRS, but for children. So simply put, we're just replacing those questionnaires, those questions around employment with questions around education and attendance. Just a quick slide on patient experience measures. So we do have the NHS Family and Friends test available, and these results can be anonymised and shared internally or externally, such as national teams or regional teams, or with anybody looking to review and improve the service. So this next slide looks at clinical measurements and demographics. So in addition to the PROMs, which focus on certain symptoms or groups of symptoms, these clinical measurements and demographics are used clinically to gain a better understanding of the patient's overall health. But they can also be used in local, regional and national reporting to undertake service audits or evaluations of patients seen in the service, and in research to identify potential trends in patient recovery or variety of symptoms. And the following fields are captured in what we call now a general health questionnaire, which is available in the app. So there are some common demographics, and also some COVID-related fields such as COVID infection history, swab test results, vaccination history in response to each vaccination. And just some questions to the audience, so feel free to put your answers into the chat and we can review them at the end. But are there any PROMs in your service that your service is using which you haven't listed there? I know I flicked past quite quickly, but if you just want to pop some in the chat, would be interesting to see. Which PROMs have you found useful? And how can we help you to better evaluate your patients without overburdening them with outcome measures? So this next section now looks at the use of PROMs in your clinical pathway with some examples of how it's done elsewhere. So it's starting off with Salford Royal, which has since merged into the Northern Care Alliance with Pennine Acute NHS Trust. So when a patient is referred to the pathway, they're assigned to the Salford Royal Clinical Centre through our platform. But if they're also taking part in Locomotion, which is a National Institute for Health Research project we're supporting, they would also be assigned to this Locomotion Centre. The way that Salford's pathway is set up, they have a dedicated team responsible for triage only, so they only look at the first assessments, and they get their patients to complete the C19YRS and EQ5D every 28 days, but they also have these additional PROMs which are asked of the patient to complete at least once. Patients are then sent to the rehab centre for subsequent assessments, the majority of which are conducted face-to-face, and there's they have the option of adding the MRC and also the Nijmegen or Nijmegen as and when needed. If a patient is assigned to local immersion centre, the setup is slightly differently. This is just the requirements for the study. So there's a general health questionnaire, the health economics baseline questionnaire, and a health economics follow-up questionnaire. If we look at Pennine Acute, which has, as I say, merged with Salford Royal into the Northern Care Alliance, but they still have 2 separate centres. This is a very rough overview, but patients are assigned within our web portal to either Bury, Oldham or Rochdale. They're asked to complete this, the C19YRS at least once, and this guides the conversation around rehabilitation and what's the plan for treatment pathways. And then following this first assessment, they have a number of optional PROMs that they want to add. This includes the EQ5D, the FACET, the modified version of the YRS. But within this Pennine Acute area, I want to highlight Rochdale in particular. So recently Rochdale ran a quality improvement project where if patients are assigned to Rochdale, instead of accepting referrals and then trying to contact all of their patients one by one, most of which are of working age, they've got families, they've got jobs to hold down, and this is proving quite time consuming to kind of pin down patients to arrange appointments. So instead, they as part of this project, they now send out welcome letters with login details to complete the first C19YRS, and this includes an invitation to opt into the service by contacting the clinic at a convenient time. So telephone appointment is then arranged at a convenient time for both parties, and they use the YRS and as part of that conversation to guide the conversation and plan accordingly. And this strategy has helped them to reduce waiting times for the service from 12 weeks down to 2 weeks. Subsequent assessments then delivered face-to-face, and then as shown on the last slide, they've got a variety of different PROMs that they want to use essentially ad hoc, depending on the patient's needs. So my final example here is Bath Swindon and Wiltshire. So this is delivered by Wiltshire Health and Care. So any patient that is referred onto this pathway is assigned to the BSW assessment centre, and they've got this different PROM configuration, and this includes the SSEQ, which is, as mentioned, a bespoke PROM that we've built for them, and this is pending validation. And depending on these results that the patient kind of presents at the first assessment, they may be assigned to one of any of these 6 different follow-on centres or satellite centres. You can see. So if they need support for occupational therapy, they might have a different PROM configuration to, for example, the respiratory physiotherapy clinic. So I hope these case study examples have been useful in showing maybe the breadth or the versatility of kind of what we can support. Every clinic is doing things quite differently. There is certainly strong arguments to try and get everybody singing to the same hymn sheet, as it were, but different clinics have got different ways, whether that's based on different specialty or skill mix within the team, or the actual capacity to kind of support any number of patients inside it. So these next 2 slides now look at discharge from post-COVID services. So this is another extract from the NHS England guidance, and NHSE states that people with long COVID can experience an exacerbation of symptoms after they've been discharged from a post-COVID service. On discharge, patients should be provided with a self-management plan and details of who to contact in the event of a relapse or development in a new symptom. And services should consider the option of patient-initiated follow-up or open referral in the pathway for a period of time to enable patients to re-access the service as they transition to self-management. And they also say that an effective discharge will also help avoid patients contacting the GP about any outstanding concerns. So how is ELAROS supporting clinics to meet these requirements? So following discharge, patient accounts can be disabled from completing further assessments. They'll still be able to access their assessment history, access the support resource within it, but they won't be able to continue self-monitoring or completing PROMs themselves. Alternatively, some clinics prefer to grant the patients the ability to continue self-monitoring via the app and to analyse these results remotely. So it's worth noting that we are in discussion with NHS England directly and also with individual clinics about how we can support clinics with post-discharge monitoring and how can you extract this data 6 and 12 months following discharge. Like with the initial assessment routine monitoring, people have got different I suppose wants and needs on how they want to kind of run the service, and post-discharge monitoring is different from clinic to clinic. So some clinics do prefer to kind of prevent patients from continuing using the app or to submit assessments, whereas other people want to grant patients the ability to do that. So to summarise, clearly we've seen throughout this webinar that a number of different outcome measures exist for specific symptoms or symptom areas. But given the nature of long COVID and the risk of overburdening patients with questionnaires, a condition-specific comprehensive assessment is needed, whatever that might be. Additional clinical measurements and demographic data are needed to gain a more rounded view of the patient's overall health and to analyse trends and conduct service valuations at an aggregate level. A lot of variability clearly exists in how long services are currently run, and this prompts the need for a versatile platform that can be configured to the local pathway to support all these different service designs. And data capture should expand assessment through to rehabilitation, but also now discharge from the post-COVID services pathway. So this final slide just shows the different categories of different features that we've got available in ELAROS platform. So we've got tools to support the clinic with initial assessment and triage, with a variety of kind of commonly used PROMs, but also validated tools, through to kind of routine monitoring, post-discharge monitoring. And we also have a variety of NHS resources built within into the app, which can also be accessed online. And so this includes various resources from Leeds, Cambridge, Salford, the Sleep Charity, Airedale, etc. And we now turn our attention on how we can support children and young people with these NHS recommended PROMs, and adapting certain elements of the app or kind of certain questionnaires to make it easy for children, but also parents to complete on their behalf in some cases. We've also got a variety of tools to support research, service reporting, and also to combat digital exclusion. Okay, that's all for me for my presentation. But if anyone's got any questions, feel free to pop them in the chat. Recording of the session and the whole webinar can be made available to the attendees. Just drop us an email. But if anybody would like to arrange a more in-depth session with more in-depth demonstration of the system, feel free to contact us on this email. But as you can see, we've got about 5 or 6 minutes left, so we'll give you a quick demonstration of the system. Okay, so every member of staff who's using our platform can have access to a staff web portal with their own account. So I'm just showing you now a demo center with some demo patients, and you see a patient list here. So with like an overview section of all your patients within your clinic. To get a patient into the system or to register them with an account, this requires 4 bits of information, which is first and last name, date of birth, health ID number, whether it's an NHS number, whether it's a Scottish CHI number, or any other health ID number that needs to be adapted from this, and also gender. Patients then assigned to a centre. In most cases, most clinics do have just one centre, but as we've seen from BSW, they've got, I think, 7. If we use Cambridge as an example, a patient would be assigned to the Cambridge and Peterborough post-COVID service, and then they've got the option of configuring localities within that centre, so then they can organise these patients out into, say, for example, Cambridge, Peterborough, or Stevenage. Once a patient account has been saved or registered, every patient has a dedicated profile, and you've got the patient banner here at the top, so you're identifying the patient at all times. And this, all these fields are currently empty because we've not completed any assessments yet. So we've got a personal or demographics area or tab covering things like height, weight, smoker status, medical history. A COVID-related data tab, which covers data of first symptoms, number of days in hospital, ICU, soon to have vaccination history, COVID infection history. And there's also an assessment list here. So this is just a demo patient that has access to all these different questionnaires, but then in most cases, one clinic might only have 2, 3, 4 PROMs, and we just hide the ones that you don't want. So once a patient's had an account created for them, these login details would then need to be shared with the patient. And this varies from clinic to clinic how you do this, whether it's sent by SMS, by email, by welcome letter. And then the patient will then be able to log into the app. So what I'm showing you here is our online version of the app. So this is a web app, which is essentially an online replica of the mobile app. And why this is really useful is this is helping to kind of get around any risk of kind of digitally excluding patients. So if the patient doesn't have a mobile phone or they struggle with reading difficulties on small things, they can access this on a computer or a laptop. Alternatively, in cases where patients needed, for example, in Bradford, as highlighted on the last webinar, patients who needed to arrange a language translator, they were able to contact a clinic, and a member of staff were able to kind of access this web app with an interpreter, and they could complete it on their behalf. So when a patient kind of logs in, they can click New Assessment, and in this case, Joseph Bloggs has access to these 6 questionnaires. It shows which assessments are due today, which assessments are overdue and by how many, and also which assessments are due in the future. So if I were to show the C19YRS, for example, we've got first page of demographics. The first question of the core domains is on breathlessness, and with this questionnaire, we ask patients to grade the severity of symptoms on a sliding scale of 0 to 10. And I won't fill this full question out today, but if I would show you, you can see here which questionnaire is left incomplete. But if I want to start a new questionnaire, say for example the EQ5D, this is being built in a particular way as per requirements from Euroqual. So in order for us to add this into our system, we had to dot all the I's and cross the T's and how it looks and feels. So once a patient has completed multiple assessments, they'll be able to see their assessment history. So if I want to look at the very first C19YRS assessment here, I can look here back at the 30th of April 2021, and I can see all the questions and answers. I recently presented to some colleagues in Ireland, and a clinic did ask us, are we able to hide these assessment results just to avoid any bias from in future assessments? That's certainly possible. We can look at that if anybody does want it. Patients will also have access to this radar port, which I've shown you in my presentation. So this is just an overview of all the different symptoms that they've kind of scored on their assessments. And all of this is sent back to the web portal. If I find this the same patient. So as soon as patient hits submit, they'll then be able to see these results in the web portal. So you can see all these fields are now automatically populated. And this is really the time-saving element. So if you can avoid or minimize the number of staff or staff hours that are spent in kind of completing these paper assessments, sending them out in the post, waiting for them to be completed, and then uploading them, however that might be, then this is having a positive impact at all of our sites. The final quick point is just on the support resources we've got available, which I've mentioned. So within the app, patients can go here, the support resources, and currently we've got these kind of these sections here. And all of these different sections have been produced by NHS organisations themselves. So from memory, the anxiety section has got content produced by Salford and the Northern Care Alliance. I think breathlessness and cognition is from Leeds, and then etc. So if I were to click on here, you'd be able to kind of see a screen within a screen if on mobile. But since we're on a computer, I'll just take you to our C19YRS.me platform. So this is a self-management platform with all these different resources kind of compiled into one. And we've got all these different sections that patients can work through online or through the app. And my final page to show you is our useful resources section. So these are all the booklets or original material that we've used or had contributed to us that we built into the app, and also accessible as a PDF to download and email to patients. These are also really, really useful for earlier clinics, perhaps with new staff and they want to kind of learn how we can approach certain symptoms with long COVID. Just one point that I remember that Adia mentioned, Cambridge and Peterborough produced these kind of nationally approved long COVID videos that are available to everybody on NHS Futures platform, but I have had permission that these can be extended to any other kind of public organisation, which needs to ask permission from Cambridge. Okay, is there any questions?
Roman, I think there's been a few that have come up in the chat around a quote and so on, which Henry's followed up with. Questions around how much patient feedback you've had. I wonder if that's something that could get that was worth mentioning. And yeah, if anybody else wanted to pick up on any questions that you have raised in the chat and expand on those, please feel free to.
Yeah, I was just going to say, with regards to patient feedback, if you go to c19yrs.com, go to our testimonials page, we've got a variety of staff feedback, patient feedback, comments from there. And I think if you go to YouTube, just type in ELAROS, we did a BBC Northwest feature, which includes a patient interview. And there's obviously the testimonial from Kerry Rigby. And the final point to mention is, yeah, Manoj and I, or Leeds and ELAROS, are working on a paper which creates a variety of kind of discovery work and also staff and patient feedback from various different centres.
Does anybody else have any questions to raise with Roman or to raise with the earlier speakers? I think everyone's gone shy.
No worries. I think there's a couple of questions about kind of quotes and the pricing. This ultimately does depend on what it's needed for. I know that Janet Scott's now left, but that this was a research project required various kind of new things to be developed, which we would have to put up front, and that's the reason why we reached that quote.
That's always useful to mention. I think we see that with any type of technology, really, that it can depend on the size of service that you're wanting to use, how many patients you're using through that service, and so on.
Yeah, definitely. I think the common one as well is when we get a new kind of site approaches, usually there is kind of some new request for a PROM that we've never seen before. That obviously takes our own time to develop. That needs to be factored in. There's a question around recordings. So I can send that through to everybody, to everybody who's registered. I realise we've only got about 50% attendance at the minute. There's people from that haven't been able to make it today. And with regards to the videos, I think that's best to contact CPFT for this. But we have access to links as well, so maybe you can drop us a line. We can share these with you.
Brilliant. So I think just checking if any other questions have come in. I think we've covered most of the questions that have come in, though. I think if there are any other queries that that you think of after the session's ended, you can email Roman and he'll be able to field those either answer them himself or field those to Manoj or AD from earlier on. And Roman has just popped in the relevant email address into the chat there. So yeah, I guess if there are no further queries, and Roman, if there are no other further comments from yourself.
No, that's it. Thank you very much.
Okay, so thank you everyone for attending. I know it's a really busy time. It is appreciated that you've attended and listened to the talks today. We will be able to share further information and answer any of those further queries afterwards. Dr. Savan has just popped his direct email address in the chat there as well, if anyone wanted to raise any questions with him about the service at Leeds directly. So thank you very much and have a nice rest of the afternoon.